So first, we're just going to start with an acknowledgement to country. So we'd like to acknowledge this land that we meet on today is the traditional land of the Kaurna people, and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. The dreaming is still living from past, in the present, into the future. And I'd also like to acknowledge any other lands that people may be joining this session from today as well. So a little bit of housekeeping rules to start with. Just want to let you all know that the session has been preset, that your microphones and your video feeds are turned off. But when it's question and answer time, that will all go away, and we'd love to see your faces. And you can pop your questions in the chat, or we can just talk to each other face to face. The session itself is recorded, but we will stop the recording for question and answer time as well, just to allow for that relaxation and that kind of free conversation that I'm hoping to have. Finally, after the Q&A, there's going to be a quick survey that we'd love you to complete as well. If you can take a few minutes to help us just evaluating today's session. So we'll put that up at the end as well. So for those of you that aren't familiar with us, we are the CEIH, and that stands for the Commission on Excellence and Innovation in Health. And together, creating health and prosperity for all is what we stand for. We're the lead agency for innovation in healthcare in South Australia. And our favourite thing to do here is to bring the consumers, clinicians and other collaborators together and to share ideas for better healthcare. This is something that I'm quite passionate about as well. My name's Katie Mayolo, and I'm the Networks Program Director here at the CIH. So I have oversight of our 8 clinical networks and work quite closely with our communities of practice as well. So here at CIH, we really do believe that in order to support the sector coming together, we need to have sessions like this to hear new ideas and hear what other people are doing that can help us all work together for a better healthcare. Saying that, we acknowledge that better isn't always excellent, but we also are committed to measuring what we do and measuring the impact that we are having. And I think that's a really important step. So what if the big idea was actually connecting the small ideas? This is in essence what we're doing here and what the Improvement and Innovation Showcase is all about. So it's not only about connecting people together within South Australia and beyond as we are today, but it's also about just sharing of those ideas, improvements and innovations that other people are doing so we can learn off and from each other. So a little bit about the series itself. It runs for about 40 minutes and then it will be available online at any time. It, as I've mentioned, it does bring different healthcare teams together, and today is a great example of that. And it just provides a really nice space to explore what others are working on, what others have learnt. I think the principle here is to keep it simple and to just share really in an honest way the work that people are doing. And that can actually be at any level. It doesn't have to have been something that was successful or published or finished or completed. I think we're interested in anything in any journey that anyone's up to of really just trying something different, trying to improve, trying to push the envelope. Like I've said, we do focus on work in South Australia, and every now and then, like today, we have a special session where we love to showcase outside of our own state to really ignite ideas. So that being said, for the listeners today, if you have a problem, if you've had a success, if you've learned something, if you're trying to learn something and you have something that you'd like to see explored further, we would love you to get in touch with us and we'd love to hear that. And down the bottom of the slide is our contact details. Please reach out to us. We'd love to hear from you. So I think that's enough hearing from me. So that being said, I would love to introduce and hand over to Dr. Kimberly Humphrey, and we can all talk about environmental sustainability in healthcare today. Thank you.
Thank you so much, Katie. All right, I'm not going to spend too much time talking so we can hear from the wonderful Dr. Kate Charlesworth. But as Katie said, this session is environmental sustainability and health care. So my name is Dr. Kimberly Humphrey. I'm a public health medical consultant in the public health division at SA Health and the climate change lead across SA Health. The reason that we have decided to showcase environmental sustainability in this series is really to try and bring across the understanding that climate change and sustainability is an integral part of what we do, including in the clinical space. It's not a special little theme that some of us care about as a little project on the side. It is important in terms of what we do and what climate change is doing to our practice as well. Hence why we really want to spotlight this issue, this series. I will give a little bit of a shout out to the Climate Change and Health Framework consultation, which is still going on. So if you scan that QR code, or if you even Google USA SA or Climate Change and Health Framework, you should be able to pull that up. And there's still a little bit of time to provide feedback on that as well. This document is really our high-level blueprint guide for what we need to do in the future. It doesn't get down into the weeds about specific goals and actions, but it is really our guiding light in terms of where we think we need to go. So we do value any feedback on that. So we'll just quickly recap today's session. We'll get into in a moment with Dr. Kate Charlesworth, so high value healthcare is low carbon healthcare. And then we've got a couple of really good sessions coming up. We will not cover everything in this space in these few sessions, but we will get into some of the things that are really important in terms of our practice. So on the 20th of June, we have a session on waste reduction in healthcare with Sarah Ripley from the she's the Sustainable Healthcare Manager at the Climate Health Alliance, and the team from the Surgical Services Division at Women's and Children's. And then wrapping it up on the 27th of June, we have a session on sustainable design in healthcare with Jack Noonan from the New Women's and Children's Hospital Project. So please do join us for those sessions if you can as well. It is now my great pleasure to introduce Dr. Kate Charlesworth, who is a public health physician in Sydney and leads the Climate Risk and Net Zero Unit at New South Wales Health. Kate initially worked as a hospital doctor in Perth and Sydney before undertaking much of her public health medicine training in the UK. In England, she worked in the Greener NHS program, the leading healthcare decarbonisation program in the world. There's certainly a lot that we can learn from the NHS to apply to our practice as well. Kate's worked in sustainability roles across New South Wales Health since 2018 and has a PhD in low carbon healthcare. And it's my great pleasure to welcome Kate to speak with us today. Thank you, Kate.
Thanks so much, Kimberly. I'll just share my slides if possible. Does that look good, Kimberly?
It does. Perfect.
Great. Terrific. Thanks so much, and thanks for having me. It's terrific to hear about this series that you have and this particular focus on sustainable healthcare. So it's a great pleasure to join you. So firstly, I'd just like to quickly add my acknowledgement of country. I'm on Cammeraygal land today here in North Sydney. And in particular, of course, to note that Aboriginal people have been tremendous stewards and custodians of this land for more than 60,000 years. And that those themes of stewardship and custodianship are particularly relevant to what we'll be talking about today. So for me today, lots to cover, but basically 3 key issues. And the first one is that climate change is a health issue. Okay. Certainly it's an environmental issue, it's a social issue, it's an economic issue, but fundamentally it is about health and about care. I'm not going to talk, of course, about the science of climate change. We're just focusing on quickly climate change as a health issue, and in particular the drivers and the imperatives now that are coming down the pipeline to New South Wales Health and other health jurisdictions as well. Secondly, New South Wales Health's net zero transition, the work that we have underway here in our state, which really, as I was saying before, is like a case study, I guess, an example for all of you. And then lastly, the close interconnection, as Kimberly has said, this is really, sustainable healthcare is not another thing to do. It's really our task to embed it as part of mainstream healthcare and high quality healthcare and business as usual. So where value-based healthcare fits into decarbonising a health system. Okay, so I really like this article. Some of you may have seen it earlier in the year because it pretty clearly sets out where we're at now in 2024. As it says, this year we have there is both cause for deep alarm, but also for cautious optimism. And the deep alarm, of course, because we are now in danger of hitting irreversible tipping points in Earth's climate, but at the same time, cautious optimism, because if you look at now the scale and pace of change in renewables, in EV sales, in clean tech, in their sort of market demands for those new solutions, then 2024 could be the year in which emissions start to level out and then decline. Okay, so that's why they say in 2024 it's not game over, it's game on. Of course, once emissions start to level off and then decline, then we'll have to go very fast. We have to decarbonise very quickly. And every sector, energy, transport, agriculture, everyone is going to have a key role to play in that decarbonisation, of our society. But the health system has a particular responsibility to do so. Because currently we're part of the problem. We use huge amounts of resources. We produce vast amounts of waste. We still use, in many cases, fossil fuel-based energy. We have a big carbon footprint. I'm sure you've heard before that globally, if the health system were a country, it would be the 5th biggest polluter on the planet. So we have a big responsibility to decarbonise. Just quickly, we also, of course, have a responsibility to adapt. Even if we stopped polluting tomorrow, there are climate changes baked into the system for decades to come. So we will need to be prepared and resilient for those changes. And as this slide from the CDC points out, it's not just sort of direct health impacts, the heat and storms, bushfires and floods and so on, but it's also all the associated and flow-on health impacts, shifts in infectious diseases, rise in allergens, food and water insecurity, mental health impacts, forced migration. All those impacts, those indirect health impacts, are equally important. And a key point about that is that those health impacts are not being equally distributed. Okay? For a whole range of physiological, social, economic, environmental reasons, it is the most vulnerable people in society. Babies and children, the elderly, people on low incomes, people in rural and regional communities, Indigenous communities, those people are being hit the first and the hardest. As you can see here, this is an example in terms of extreme heat. During an extreme heat event, in Sydney, for example, it's not the wealthy people in the harbourside or beachside suburbs who can afford air conditioning. They're not the ones who die. Okay? It's the people who might be in social housing out in inland, in sort of areas of Western Sydney, who can't afford air conditioning, who are stuck in the top flat of an apartment building. Those are the people who are most at risk. And so climate change is also an issue of social justice and health inequity. Okay, so we have a responsibility to decarbonise and adapt, and there are a growing list of reasons for us now to do so. This is obviously New South Wales health focused, but similar in many jurisdictions. And previously I've sort of talked more about the sort of health and the environmental and the sort of ethical reasons for us to decarbonise, which I would regard as sort of like the carrots, I guess, the sort of softer reasons. But to be honest, now there's a growing number of sticks. At New South Wales Health, and I'm sure in SA Health as well, we are now getting asked about climate risk disclosures and what our plan is now. We're getting advice from New South Wales Treasury about carbon pricing. And the biggest stick of all for us, of course, is that in New South Wales, it is now the law. Under the Climate Change Act, which was passed late last year, we have to reduce emissions by 50% by 2030. Other states, Victoria's had legislation for some time. Of course, nationally, there is the Climate Change Act as well. That was legislation of 2022. And we have to reduce, nationally, have to reduce emissions by 43% by 2030. So these sorts of requirements are coming into play. I just point out regulatory requirement, of course, the Australian Commission on Safety and Quality in Healthcare, which obviously sets all the hospital and healthcare accreditation standards across the country. They have developed a sustainable healthcare module that was passed last year. They're piloting it this year, but signalling that that's going to become a mandatory part of accreditation standards. So there's a lot of these sort of requirements that are coming our way, both the carrots, I guess, and the sticks. Again, New South Wales Health example, but applicable more broadly. We are, as you can see, that this is CASPER data. This is publicly available data about our energy, water, and waste. And as you can see there, that's health on the left. This is just a snapshot of the electricity consumption, for example. So you can see health on the left dwarfs education, communities, transport and others. We are the highest emitter across New South Wales government. This is not surprising. It is consistent with what we see from other jurisdictions and also internationally. We know that health systems are big polluters. We're big systems, we deliver pretty complex and often carbon intensive health systems. So it's not surprising, but it does mean that for health systems, as we pointed out, we have a particular responsibility, particular task ahead of us. Okay, so what are we doing in New South Wales Health? It's pretty hard to decarbonise a health system if you don't know what your starting point is. So in the first year, my team's been going for probably about 2 years now, I guess. In the first 12 to 18 months, we spent a lot of time on carbon footprinting. So we've now carbon footprinted 3 local health districts. Our LHDs are comprised of about 4 tertiary hospitals and a couple of, some other, community health centres and others. So we've done 3 local health districts, regional, a metro one, and also the Sydney Kids, which is our children's hospital network. We've also carbon footprinted 2 hospitals, again, a regional based hospital and then a large metro tertiary hospital. So we've got pretty good snapshots of all of those. This is one example. This is CCLHD, which is Central Coast Local Health District. So I guess the sort of regional area immediately north of Sydney. And you can see that the results. I won't go through it all, but the key points are the scope 1, 2 and 3. So scope 1 are our direct on-site emissions, so gas, including medical gases. Scope 2 is our purchased electricity, and scope 3 are all our supply chain emissions. That's the embodied carbon and all of the things that we buy and use and order and prescribe every day. So 2 key points from this. Firstly, when people ask me what I do and I talk about that, they immediately think, oh, she works in solar panels on hospital roofs and net zero ambulances. Those things are important, but as we can see from this, it's nowhere near the whole story. Okay, so scope 3 emissions are significant. It's a key thing. And secondly, the case I would make here is that clinical decision making, it's our models of care and the structures and the way in which we deliver care that are really at the heart of decarbonising a whole system. Because whether or not patients get sick in the first place, so what we have in terms of health promotion and disease avoidance, that's critical. And then whether patients are treated in the community or in a tertiary and carbon intensive hospital, whether they have investigations or procedures that we get into low value care, and then also what type of equipment we use. All of those things, they're really clinical decision makings and models of care questions, and those sort of things drive all the rest. That drives energy, it drives transport, it drives food, it drives linen emission. So the clinical decision making is really critical. So an overview of what we have in New South Wales Health. My team works alongside our colleagues in, as you can see there, energy and transport, who are responsible for all the energy and fleet and other initiatives. Health infrastructure, build our hospitals. Health share, provide all the support services, so food, linen and patient transport and so on. And ACI, which is our Agency for Clinical Innovation, which sounds quite similar to your CIH. We work really closely with ACI. My team is focused on clinical care, but we work really closely with our colleagues in all of those different areas, and each of them now really have small sustainability teams as well. So probably 4 or 5 key teams involved in that. This is just one example. This is the new Maitland Hospital car park. As you can see, that's a renewable energy project. Those are solar panels in the car park. But importantly, it's also, of course, an adaptation initiative, because those panels are providing shade for patients and staff and visitors coming and going from the car park. So a protection against extreme heat as well. So just a nice example of mitigation and adaptation measure. Okay, so really critical to look at governance and performance management. I have the good fortune that my team sits within a division called Systems Sustainability and Performance, which is really responsible for the KPIs and the service agreements and others. So we were able relatively easily to implement some key performance indicators. So the service agreements in New South Wales Basically, the Ministry of Health, the Department of Health, provides funding to all the local health districts, and in return, the LHDs have to provide services, and they're governed and managed through a series of KPIs. This financial year, we had 5 new KPIs in our service agreements. As you can see, they're about DES and nitrous oxide, also energy, fleet optimisation and waste. So that's a really critical driver for us. Alongside that, so they're sort of the quantitative sticks, I guess, we also have these qualitative measures. So we wrote to all the chief executives and said, these are the 10 things that we really would like to see in your organisation's approach to climate risk. So as you can see, they're including sustainability and strategic plan, appropriate human resourcing, having reviewed a carbon footprint assessment, recognising staff achievement, supporting staff in education and training, having it as a priority theme. I think this is really critical across quality improvement and research and innovation and redesign. So those initiatives have been, this guidance has been really well received as well. We're increasingly starting to see local health districts integrate sustainability across all of these areas. And then I guess the sort of really critical area about decarbonising clinical care, which, as I've said, we think is at the heart of decarbonising a health system. So when I speak with our nurses and doctors and physios and pharmacists, all our staff involved in frontline care or clinical care, I say this is the most important slide for you. This is our whole approach to decarbonising healthcare. If you just stood back and said, okay, how do we get to a net zero health system? These are the 3 things that you would do. Okay? 3 principles of sustainable healthcare, and based on work from the CSH, which is based in Oxford in the UK. So principle number 1 is keep people healthy and well and independent. And that's because one type of carbon neutral health system would be a system in which we didn't have any patients. Everyone was healthy and well and independent in their homes and their communities. So it's really just in recognition of the fact that so many of the things that many of us and our colleagues do every day about, tobacco control and obesity policy and active transport and vaccination, all those sorts of things to keep people healthy and well, the health promotion type, the public health type initiatives, they are actually sustainability initiatives. So that's the first principle. We always have to keep that in the forefront of our minds. The second one is about minimising low value and harmful care. We know there's a substantial amount of overdiagnosis and overtreatment across our systems, and those things have harms and risks and also costs, not just financial costs, but also carbon costs. Okay? So I'll talk a bit more about that. That's the second principle. And then the third principle is saying, okay, where we do have effective and evidence-based care, how do we decarbonise that? And then those questions are about what type of anaesthetic gas are we using? What are we doing about single-use plastics? Those sorts of questions. So just a couple of examples, I guess, on the first one, just to really illustrate those 3 principles. This is the first principle, and this is just an article talking about the effectiveness. There is now pretty strong evidence in the sort of health and medical literature about the high effectiveness of physical activity programs. In this case, they're saying exercise is even more effective than counselling or medication for depression. And I guess just to back that up, this is from Public Health England. And as you can see there, it shows that physically active people have lower health risks across a whole range of chronic health outcomes. And these are quite substantial declines as well. Reduced risk of dementia by 40%, type 2 diabetes by about 1/3, some mental health outcomes, some cancers, and obviously heart disease and stroke and other things as well, all-cause mortality down 30%. I often say, if physical activity could be bundled up as a pill, then the pharmaceutical companies would be falling over themselves to get it. It's really such a highly effective, safe, high quality, low cost, low carbon intervention that confers really significant health benefits. Okay, so that's just an example of the first principle. Second principle, low value care. This is a paper that we published in the MJA, the Medical Journal of Australia, a couple of years ago. And I'll just talk you through it. So on the left, the pie chart there is a very simplified representation of the Australian health system's carbon footprint. Okay? Basically, they're saying, okay, 20% is directly buildings, energy and gas, but 80% of Australia Healthcare's carbon footprint is related to clinical care. It's clinical decision making. Okay? And then they've extrapolated that 80% over to the right and said, okay, based on the literature, this is the work of Braithwaite et al., we know that about 10% of care is harmful. Okay? That's where a patient goes for an unnecessary test or unnecessary procedure or unnecessary medication and have a bad outcome from that. That's harmful care. So 10% of care is harmful, 30% is low value care. Unnecessary tests, unnecessary investigations, unnecessary procedures. That's low value. So what we're saying there is if you add together 2 and 8, we are currently wasting more than 10 million tonnes of carbon on harmful or low value care. And that's why it's the second principle. It's the second thing that we need to consider after the primary prevention. Again, just to illustrate that second point, this is a paper about orthopaedic surgeries. The authors here are saying that if you look at good quality evidence, then they found that interventions such as shoulder and knee arthroscopies and spinal surgeries are no better than something like an exercise program for achieving good health outcomes. And yet, something like 1 in 6 patients who undergo spinal surgery will have a bad outcome. They get a clot or an infection or get held up in hospital. Okay, so that's just an example from orthopedics. Of course, there's examples in every medical specialty, in every craft group, in every area. You could talk about CT PA scans for suspected PEs. You could talk about vitamin D testing in primary care. You could talk about imaging for lower back pain. A whole bunch of areas in which we know there is low value care. And as a second principle, we really need to address that. And then the third one, decarbonising high value care. If you're going to start to include or consider carbon footprinting in your clinical decision making, then you need to know what the carbon costs of things are. Okay? And there is now a growing literature base in medicine documenting carbon costs of different things. This paper shows the carbon cost of imaging. So what's the carbon cost of next chest x-ray, CT scan and MRI and so on. But there's a growing literature base, as I said. You can now look at the carbon cost of cataract surgery, carbon costs of cesarean section, carbon costs of different reflux treatments. That is very important information for us to be sharing with our clinicians. So in New South Wales, one of our sort of key programs, I guess, is our Net Zero Leads program, and basically recognising the importance of our clinicians, of our frontline staff in decarbonising clinical care. We've funded, I'll come back to this one. We've funded 10 of our staff, just 1 day a week each, to lead on net zero projects in their service or specialty. So staff from across nursing, allied health, pharmacy and medicine in these areas have been engaged. Actually, it's been a pilot program that's coming to its end this month, but we're hoping to extend funding because the interim results show it's been highly successful. We wanted to know when we did our carbon footprinting, what were the key areas for us to focus on? And these are the results. Theatres, these are our big carbon hotspots. Theatres, ED, imaging, women's care, and ICU. And increasingly with sort of more as the literature improves, and now thinking things like the sort of endoscopy suites, cataract surgery, those other areas might be the sort of next in the next cohort that we look at. So we have staff in those areas. Just to provide a couple of examples, I guess, of the sorts of things that they've done. We actually had two anaesthetists as our leads because the initial footprinting, and it's improved since then, but was suggesting about 5% of a hospital's carbon footprint was from anaesthetic gases. Desflurane, as you might know, a big culprit, highly polluting anaesthetic gas with a global warming potential 2,500 times that of CO2. So we had our leads we had 2 leads, one sort of working on DES and one working on nitrous oxide. Nitrous, again, global warming potential about 300 times that of CO2. We started to track, for example, our desflurane use. This is over the last few years. We were able to go back a couple more years. And I think this tells a really important story because as anaesthetists were informed and engaged on the desflurane issue, as they started to understand the environmental impact, the high environmental impact of desflurane, they have shifted away from desflurane towards clinically equivalent alternatives. And this is our DES use over the last few years, more than 4,000 tonnes of carbon in 2019. Now we're tracking about 500 or 600 tonnes of carbon. Some of you might know we've actually recently, the New South Wales Health formularies removed desflurane from our formulary on the basis of environmental sustainability considerations, but also cost, and also the fact that there were clinically equivalent alternatives available. So we expect now, we take desflurane off our KPI list, and we expect it to tail off. And this just can still access it through an IPU, an individual patient usage form, but the use is tailing off, as I said. So that was anaesthetics, net zero ED leads, Dr. Brian O'Connell, working on a bunch of things, but really focusing on that second principle, which is about reducing unnecessary tests. It's about reducing unnecessary blood tests in emergency departments. Interim results suggest about a 30% reduction in pathology costs. So some early encouraging results there from Brian's project. Nursing, we had two nursing leads. Rowan Hutchings is a theatre nurse at Orange Base Hospital, which is one of our regional hospitals, and was looking at reducing unnecessary waste, so surgical preference cards. And Rowan's found a significant amount of wastage from items that were opened in anticipation that the surgeon would want them, but then discarded, completely unused, because the surgeon's preference cards weren't updated. And so other items then had to be brought in and used. So just quite a simple project, but really highly effective in reducing waste and emissions in theatre. Net zero surgery lead, Dr. Stanley Chen. That's not Stan, that's just a generic photo. Again, as we saw, theatre is a highly big carbon hotspot in healthcare. Stan's got a whole bunch of projects underway, but I guess the main one is looking at reusable linen. So theatre gowns and drapes and so on, and whether we could be reusing, going back to sort of the older fashioned type linen, which could be cleaned and sterilised on site and reused. So project there. Allied Health Lead, highly successful gloves are off program. Basically found there's a huge amount of unnecessary these are just non-sterile glove use in hospitals. Staff were using them to wash the baby or push a trolley around or put up a fluid bag or something. Completely unnecessary and inappropriate use of gloves. Just ran a staff education and engagement campaign, has reduced glove use by about 20%, saving, sorry, they're not updated data, it's about half that, about $1.5 million, but saved several $100,000 from that project. Low cost, highly effective project, reducing waste, reducing emissions, actually improving patient care, of course, because we know that inappropriate glove use is actually associated with a higher risk of infections. I might just really quickly zip through our roadmap. This is a key piece of work for us this year. We've been tasked, obviously, given the law now in New South Wales, tasked by our secretary with developing an approach for how we're actually going to meet those targets. We've looked at the Greener NHS, which has actually mapped out their targets, looked at the National Health Strategy, and developed a draft roadmap for us. Those are our 6 priority areas. We've run a strong consultation over the last few months with consultation sessions for our staff, and then also just a community-based on the Department of Customer Service, publicly available, Have Your Say platform. More than 2,200 contributions to that. So we're now in the process of analysing that. This is the sort of thing that I'd like us to do in our roadmap, is setting out all the things that we need to do. This is based on NHS work. As you can see on the x-axis, 2008 up to 2050, the carbon emissions on the y-axis, they showed their emissions to date, and then set out all those different colours, the actions that they needed to do to get to net zero by 2040, which is the NHS target. I'd like us to do a similar thing with a sort of a case study. If we're talking about like theatre waste, for example, maybe that's say in dark blue, then have a specific case study highlighting what we're actually doing. This is one of our projects in which theatre staff are shifting from plastics to the stainless steel theatre hollowware, the bowls and galley pots and kidney dishes. Saving carbon, saving money, and also staff staff really prefer that, using that high quality equipment as well. So that's a good example. I'll finish off there. This is my second last slide, just to really finish with these twin messages, I guess, of risk and opportunity. I think John Kerry sums up the risk part pretty well, but also, and this is my final slide, I love to finish with some David Attenborough, but what a privilege for us to live on this planet with such incredible beauty and diversity. And as in Aboriginal culture, we are custodians, we are stewards of this land, and it is our responsibility to protect nature and these ecosystems upon which human health is entirely dependent. As David Attenborough has said recently, we are in danger now of hitting these tipping points and the collapse of the living world, but yet we still have the opportunity to put it right. So in 2024, it's not game over, it's game on. Thank you.